Welcome, everyone. We're going to be getting started very soon. Welcome, everyone who's joining. We're going to be getting started very soon.
Hi, welcome everyone. We're so glad that you can all be here and join us today. My name is Melissa. I am currently on the conference committee and I am a grad student at Tufts University working towards my M.P.H. And it is with great pleasure that I introduce to you today our next speaker, Dr. Audra Meadows. She is a birth optimizer and health equity champion. She cares for women before, during, and after pregnancy to ensure positive pregnancy and birth experiences. As an OB-GYN and maternal health advocate, Dr. Meadows actively investigates strategies to optimize infant and maternal outcomes and to eliminate racial and ethnic disparities associated with birth. For more than 15 years, she has been passionate about achieving health equity and creating value in clinical practice. In her previous roles as assistant professor and faculty at Harvard Medical School and the Brigham and Women's Hospital, Dr. Meadows taught medical students and trainees and devoted time to prenatal care practice innovation advocacy. She has served as medical director of the BWH Ambulatory Obstetrics Practice, the Boston Healthy Start Initiative, and BWH Stronger Generations Program. Presently, she co-leads the Perinatal Neonatal Quality Improvement Network of Massachusetts and serves as faculty and board member for the Institute for Healthcare Improvement, Better Maternal Outcomes Project, and the Institute for Perinatal Quality Improvement. In this work, she leads quality improvement projects to promote learning and tools that improve obstetric safety and equity. So it is with great pleasure that I segue into for you, Dr. Meadows, to start.
Thank you, Melissa. Thank you, everyone. I'm just going to say hi, and I have my camera on for now, but I'm actually going to turn my video off as we get ready to talk, because I want to make sure that we are focused in on the information. With that, I would like to say thank you for having me. I'm excited to be here. I'm very moved, as I know many of you may be as well, by the conversation we just heard from Mama Shafia. I was getting ready to say Dr. Mama Shafia, because that conversation was a doctorate level discussion of what we need to be doing. And I have many of the same points in my slides, so I'm going to really move through some of the slides a little quickly. In the chat, if you feel like I'm going a little too quickly and want me to slow down on a particular topic, please don't hesitate to put a question into the chat. What I'd like to do, though, is get to the questions that I also have so that we can have a bit of a discussion, which would be fantastic. So I have no disclosures or financial relationships to report and wanted to move straight into our objectives. So this is a half-hour session. So the goal in this is really to have a discussion and to make sure that you leave here with at least an understanding of the overall rate of maternal infant mortality, maternal and infant indicators in the population of the US that indicate our population health. You heard much of this from Mama Shafia. As well, we want to describe the factors that contribute to racial and ethnic disparities in these maternal infant outcomes. You again heard much of this from Mama Shafia. We really want to get to the meat of some of this, which is to then list these pregnancy support models, which includes doula support, that improve outcomes and eliminate disparities, and how we could move forward in that direction. I want to put this slide up first because this is our human rights crisis. The US has the highest maternal mortality rate among developed nations. The US rate is rising while other high-end country rates are declining. Our rates are high relative to others for infant mortality as well as maternal mortality. And with that, Black women are 2 times the risk. Now, this information that you see here is from 2018 data. They have just released from the CDC the data that shows the 2019 data, and this number for the US has now gone above 17.4 to 20. So those numbers we still see are rising, which says we still have much work to do. Mama Shafia showed an example of this slide, which is a different version. I also really enjoy this publication that you can find online at the Commonwealth Fund by Dr. Lori Zephyrin and Dr. Eugene DeClercq. Lori Zephyrin is a friend, and so I really appreciated the work that her agency put into this publication. This shows, again, half of pregnancy-related deaths occur after the day of birth. And so 31% during pregnancy, 17% around the time of delivery, and then up to 52% postpartum. So this is happening squarely around the time that women are in the care of providers. So for those of you on the call who are providers, this is why this is so important for us to really think about what are the clinical interventions and the ways that we can engage and team with clinicians in this work. Racial disparities exist. We heard also from Mama Shafia that with maternal morbidity and mortality, that the rates for Black women, the tall purple bar, is highest. And we see that this is over time frame. So if you're looking at this slide, this data shows that the maternal morbidity, so the death, not morbidity, mortality for Black women is highest. And there's about 700 women die each year in the US as a result of pregnancy complications. 50,000 to 100,000 more are experiencing these morbidity or illnesses related to pregnancy and pregnancy outcomes. But the rates for Black and Alaskan Native or Native women and American Indian are 2 to 3 times as high. So we do know that this space falls squarely in providers thinking about what can we do to address health inequities. And, again, I want to say my slides are very much complimentary of what Mama Shafia said. To the point of her comment, I'm now going to almost want to change this slide. The first time I had heard this concept that women are not dying because of diseases we cannot treat, they are dying because societies have yet to make the decision that their lives are worth saving. I heard that from Dr. Fathala, who's the past president of the International Federation of Gynecology and Obstetrics, almost a decade ago. As Mama Shafia said again today, this issue is not about a predisposition of Black women to die in pregnancy, a physiologic or genetic predisposition for Black women and Native women to have, and Hispanic women to have higher rates of illness during pregnancy, a predisposition for Black infants to suffer and a preterm birth or suffer an infant death. This is not about genetic predispositions. This is about decisions in our care system and our societies to make a difference. Again, our human rights crisis, as we continue to look at infant mortality rates, those are the rates of death per 1,000 live births. So even more frequent than maternal deaths, because maternal deaths are per 100,000. Look at that green bar on top. The United States far outpaces other countries that have an average of the blue bar around 3. If you want to know specifically in the Massachusetts area, I saw some folks I want to say hi to, especially Erica Rodriguez on the call. If you look at Massachusetts, within Boston, the rate of infant mortality for Black women in Roxbury has been as high as 11 and now down to around 9 and has gotten as low as 7. But the rate of infant mortality in Brookline, 1.9 miles away, is 2 and 2 to 3 on average over time. Infant mortality is highest among southern states, as you can see in this map of the United States, where the blue is highest, is darkest across the southeastern border. No surprise there, that's where more African Americans or Black Americans live in this country. Infant mortality rates are highest among Black infants. So this graphic shows the blue bar at the front being the tallest, that is for Black non-Hispanic infants, followed by American Indian, Alaskan Native, and the Native Hawaiian. Infant mortality is highest among those under 20. So when women are pregnant, our teen moms, as Mama Shafia said, you're thinking about our teen moms. So when you're under 20, you have the higher rates of infant mortality, and then that rate continues to decrease, but then goes back up, in the older age brackets. Why? Why do Black infants suffer higher infant mortality rates? Infant mortality rates are led in this country by congenital malformations or birth defects. However, for the Black community, preterm birth accounts for the Black-white infant mortality disparity. Over 23,000 infants died in the United States around 20,000 per year that for this infant mortality rate. There is no acceptable number. There are goals set by Healthy People 2030. There is no acceptable number. In this graphic, I show you, if you're age 15 to 19, that green bar that goes the farthest out to the right, that is African-American or Black babies born prematurely that have suffered infant death. If you live in Texas, if you live in Massachusetts, you live in other states, that tall red bar where it says live in Texas, I'm just using this to show that no matter where you are for Black infants, the reason for the higher rates of infant mortality, whether it's cut by age, income level, education level, this is not about poverty. This is about racism and discrimination. You'll see the reason being because of preterm birth. Preterm birth is highest among the Black babies. And here you'll see from the March of Dimes Peristats information that preterm birth rates by race show Black, then American Indian, Alaskan Native being the highest. And again, preterm birth rates, we saw just where those infant mortality rates were highest in the southeastern portion of the United States. You see that for the preterm birth rates as well, because we know that that's the relationship there. Importantly to note as well, March of Dimes Peristats data and the National Center for National Vital Statistics System reports that preterm birth rates are rising again. From 2015 forward, for the last 5 years, we've seen an increase. Okay, now let's stick a landing on, we have maternal morbidity, mortality issues in this country. They're rising, they're high, it's a human rights crisis. We have infant mortality numbers in this country that are high. They've actually been decreasing somewhat, but they remain ridiculously high and far exceeding other places. This is a human rights crisis for women having babies in our country. And we see a racial difference where Black women and Black infants suffer disproportionately. And with that, we need to engage and do something different about it. And the reason for infant mortality differences is that of preterm birth. When you look at preterm birth or premature birth and low birth weight, and you think about this in terms of like really then now digging through those causes, we can think about this as an issue related to risk or an issue related to care. Now, to Mama Shafia's point, this is a disparity, a difference in numbers, and it keeps getting reported as a disparity, but we know from the evidence, from the data, and from empirically, as a practicing OBGYN myself, I've been practicing for over 17 years, and others who practice, this is an inequity, not just a disparity. A disparity is a difference, and an equity is when you have a disparity that is due to unjust causes. And the unjust causes here are related to discrimination, structural racism, institutional policies, bias, microaggressions. I can name them on the list. And with that, when you think about the differences of preterm birth, a baby that's born preterm, is this because of a difference in risk? Genetics? No, we know that race is not a proxy for genetic differences. Is this a difference in environment? Yes. A difference in environment that is not explained by poverty and education, but mostly explained by stress and the issues related there, and the issues related to how that stress can impact someone's system physiologically, their neuroendocrine system, their immune inflammatory system. The generational effect that we see is also understanding the effect of racism and bias to create that stress. When you also think about, well, despite the risk, what about the kind of care that someone receives? Does that lead to preterm birth? Well, there are differences in access to care that could be related to premature birth, especially related to women who have not initiated prenatal care early. The issue is really more differences in the care received. And so rather than looking at farther, what is the problem? We want to think a little bit more about what are the solutions? Where are the opportunities? So I want to take a moment to ask this question, and I'm going to take a look at the chat and see what you guys are chatting in. What is the OB care providers? And when I say OB care provider, I want to make sure I watch my words there. I'm being inclusive of everyone. I'm thinking about the obstetrician, gynecologist, the family medicine doc who practices obstetrics, the midwife, the certified nurse and certified professional midwife, those who practice care prenatally. What is our role in reducing preterm birth and eliminating infant death disparities? Anyone want to put anything in the chat? Educating, supporting, I love that. nutrition, assessing needs, listening to birthing people, being prepared for emergencies, comprehensive, culturally competent, holistic prenatal care. Yes, embracing evidence. These are moving pretty fast, so I'm just reading quickly. Believing birthing people, being informed, engaging partners, learning, advocating for mothers. Yes, these are the answers. Supporting and having culturally competent training. So I've included a list here, and then your list is more comprehensive. This can go on. Centering birthing people's voices. I love that, Candace. So to eliminate maternal infant morbidity and mortality inequities, I've tried to practice what I've preached around having providers have the awareness of medical, social, economic, and political factors that are leading to these inequities. I have taught residents for years, and oftentimes coming from medical school, many were not aware that there were these differences, that there were disparities in the numbers, and that these disparities were due to injustices in society. They had no understanding necessarily of social determinants of health because it's not always taught across all medical schools. They don't have an understanding or an idea of structural racism, and that we know to be true still, because if anyone has heard or knows about what's happened with the journal of, the AMA's podcast on structural racism that's really gotten a lot of attention, that has become a really big issue that some people are saying they're still not understanding or don't want to talk about racism. That's still happening right now. So we need to continue to raise awareness, speak up when we see inequities. Thank you, Dr. Job. Empowering birthing people. Thank you. Yes, Susan Hernandez. And good to see you again twice in 2 days, Susan. We want to change and adapt practices so we can implement pregnancy support models of care. And so I'm going to come back to doula on this. You guys are hearing it in the words. We want high quality, patient-centered, evidence-based care, because we want to know what direction that care is going to go and where to plug in that care. So that's what the equity is, right? Where to plug in the kinds of models of care that lead to the outcomes we're looking for. So if we're looking to reduce cesarean rates, we're talking about models of care that have shown to reduce cesarean rates. If we're looking to improve patient access to information and knowledge, we want to plug in models that do that. We also need to continue to encourage and engage everyone in the research process so we can build the evidence and continue to train our future providers in the direction we want them to go. So question 2, what are examples of equity-focused interventions and actions in clinical practice? Give me examples of models, because I know what we've been saying, like what Kit Cox put in, partner and father outreach to strengthen supports. Yes, those are some examples. What about some additional, implementing AIM safety bundles? Thank you, Anna. Centering pregnancy. Yes. Yep. Group prenatal care models. Exactly. The JJ Way model. Yes. I remember the first time I heard Jenny Joseph is actually going to be speaking, and I'm so excited. I can't wait to listen to her. The JJ Way model. Yes. Patient-centered research, absolutely, getting them involved in research, including doulas in the care team. And I love, if for those of you who know me well, I speak of the words teaming often, and I love that Mama Shafia had an entire slide on what it meant to help to team the doula with the care providers, which is really important. And there's more research that needs to be done on that so that we can understand from the voices of women and from the voices of doulas and from the voices of providers what teaming looks like. So this is an example here. This is a maternity care experience map. And so if you move from this map, looking at the screen from the left to the right, as a person enters prenatal care, goes through their inpatient admission for care, and then if they're postpartum and outpatient, what are some ways that we can engage in equity-focused care? And among them, there are lots of things that we can do, but among them, some of the models, hey, Ariel, yes, training Black and Brown community members to be birth advocates, absolutely. That's on the list. These are things that I can continue to update and adapt this maternity care experience map, because on there also I have care options. If you look on the left side, extra prenatal care, 1, 2, 3, 4, 5, 6, 7 down, care options, group prenatal care, dual support. Women should have options to have individual care, group care, have a doula, not have a doula, be able to deliver at a birth center. I will say one thing I would say is if a patient is a patient of mine who's a pregnant birthing individual, and they want to have a different kind of delivery than what will be provided at my high risk academic, high volume institution, then I totally agree with bringing on additional abilities to have midwifery support at the delivery or deliver in a place that fits what the woman wants for her experience or the birthing individual wants for their experience. And so I love that we've been talking also about making sure that people have choices. So this is just an example. I'm not going to go through all the dots in here, but there are lots of things that we can think about and we can start to map together in the prenatal care time frame, in the inpatient admission, in those postpartum care. Because as I showed you on that one slide that shows that when the most grim outcomes are happening, infant deaths, maternal deaths, or morbidity, those are happening prenatal, inpatient, outpatient, through things that are happening and institutional policies that are maybe missing to prevent these things. And we can start to think about plugging in the gaps. Pregnancy support care models, what are our goals? I'm just going to touch on this because you've said most of them in the chat already, what our goals would be, but I'll include improving our birth outcomes. We want term, vaginal birth. We want teams that promote vaginal birth. We want medical systems that promote vaginal birth, that are set up to support freedom of movement in labor, continuous labor support. We want prenatal care that helps to reduce risk of harm and optimize healthy behaviors and educate, not just through providing, here's a form and here it is, but for instance, in these pregnancy support care models that we're talking about, group prenatal care, doula care, making sure that shared decision-making is happening and that there's active learning going on and not just someone being handed a brochure, here, read this, and hopefully you'll have healthy behaviors, because that's sort of that blame the victim model. This is a partnership in what we're doing. We want to build partnerships to manage expectations of care and increase skills related to caring for and advocating for ourselves, infants, and our families when we're pregnant and expecting. And also helping to meet the high, and we should help women set high expectations for their experience of labor and birth and help meet those high expectations. So I wanted to show, just watching the time, checking in with my group on the time, this slide, I have a few more to go, on the value of these pregnancy support care models. And I'm including doula care as a pregnancy support care model, because when I think of doula care, I think of the doulas that are on L&D. And then to Mama Shafia's point, making sure doulas are available for that physical, emotional, and informational support during their entire prenatal care, labor, birth, and postpartum. And then also I'm learning and growing and understanding the role of the community-based doulas, where community doulas also feed in more connected support to navigating the healthcare system and navigating community resources for those who have specific needs, especially related to housing and health coverage. And yes, Leslie added in, without a living wage and universal health coverage and paid family leave, we'll continue to see inequities. Yes, those are those structural issues. And so I'm actually, Leslie, you're going to make me want to go backwards here to say, when I was medical director of our clinical practice, that first dot next to prenatal care, under prenatal care, screening for social determinants of health, and then the second, refer to community resources, we have to have policies in our healthcare systems, in our clinical practices, to be able to do that where we're able, especially. And making sure that risk screening and counseling is happening and doing it with validated universal tools, and training our providers with upstandard training so that we're not introducing our own biases into that work. So I'm going to move forward. So the evidence for some of these models is that we know with group prenatal care, or for those of you who don't, with group prenatal care, there are 3 randomized controlled trials that have demonstrated benefit, the benefit of the things that we're looking for. These models get us to where we want. We want to make sure that there are less cesarean deliveries and we're promoting vaginal birth. We want to ensure that women are delivering at term and having less preterm births, that they're having higher birth weights, increased rates of breastfeeding initiation at delivery, continuation at discharge, continuation at 6 weeks postpartum, and supports in between to help them be successful. Being someone that struggled with breastfeeding my entire first 5 weeks, I am a strong proponent of that support. Higher satisfaction with care, increasing higher satisfaction of care and reducing dissatisfaction, which sometimes can be two different things depending on how you're studying this. With doula care, we know there's growing evidence. I have the unique, distinct pleasure of being part of an R01 funded team from the NIH through Tufts and Dr. Amuta to study the effects and supports that doula offer to care to see if we can improve outcomes for women. But the studies that we have right now, thinking of the studies that were published, specifically the Cochrane review in 2017 that looked at continuous birth supports, we saw that there were decreased in cesarean delivery, decreased use of epidurals, so medications for pain, increased rates of breastfeeding, and higher satisfaction. But what I want to dig into a little bit with that is this. When you look at continuous labor support, support, but then you add in doula. Many of the studies were able to find that if you have a decrease in your cesarean risk for continuous labor support, and so the way this is phrased is a little tricky. Like if a hospital's labor cesarean rate is 32%, and you have this decrease of a relative risk by 25%, then it's going to be less than 32% for you if you get in continuous labor support. But we have also seen in studies that when you add a doula to that continuous labor support, you also see an even greater decrease in your risk of cesarean. So this 39% decrease of that 30% really drops you down to possibly now a 20% risk of cesarean for all the reasons that a cesarean might need to happen for the purposes of saving mom's life, baby's life, improving care. So, when it comes to C-section, there's a balance. You don't want to overuse cesarean, which we have in this country. You also don't want to underuse cesarean, because when you're underusing, you're missing the opportunity to really rescue mom or baby in the process of labor when a better outcome could have been affected. So we do know that there's evidence that shows that there are some decreases in cesarean, increases of your chances, I should use the word chances, of having a spontaneous vaginal delivery, decreases your chance of a cesarean, and increases your chance of satisfaction by decreasing your chance of having dissatisfaction. Now, so with continuous labor support with a partner, family member, but not hospital staff, you got that 31% decrease. And then when you added doula, it was the same, but we didn't see that same level of decrease in some studies with just hospital staff alone. Okay, so looking at the time we have, I think we have 4 minutes left in the hour. So I wanted to take more time to talk about the steps to implement these equity focused practice, but I'm going to just show this main slide and say that if you apply quality improvement, which is my background of expertise, and you start first with teaming, identifying who your team is and the patient, the birthing individual, and your doulas, your nursing staff, your physicians, your PAs, everyone, they're part of the team. But you're doing this work in your clinical outpatient practices, you want to identify your team within your practice. For me, one of my teammates is on the call, Jen Berry. She was my teammate in getting group prenatal care off the ground at Brigham Women's Hospital. We gathered and we reviewed data. We reviewed our policies and practices, and we thought about where we can make those edits. We designed what we thought would be the best interventions to try and get this new practice model in place. And then we worked on operationalizing it through PDSA cycles. And so here's our aim statement and our PDSA of what we were doing. I wanted to just lean in quickly on what some of our factors of success were. Having motivated providers, having buy-in from leadership and your clinical staff. Money is important, obviously, when you're adding in and changing these clinical practices. So that's going to be important. So I'll talk about that with number 8 with policy. Anticipate the changes and tackle problems. Be very organized. Offer frequent and clear communication with your team, because it's hard when you add in new practice patterns into already existing systems, because you want it to succeed and it can easily fail without that organization and clear communication. And then evaluate your data and demonstrate your improvement, because that's one way to get some money to keep moving forward. And so I want to just land on and stick the landing here to say, with all the factors of success, work on teaming and work on policy in order to be successful there. I was going to show some outcomes from our group prenatal care at the Brigham, which we showed also decreased cesarean birth and NICU admissions and an increased savings for payers. But what was important is that I didn't get a chance while I was there to look at how to integrate doulas into our practice as an outpatient, but that was next on the list and probably still on their list as that work is moving forward. And I just want to say, let's move forward together through policy. There's a lot of action out right now to try and move policy through states to allow for doulas care to be reimbursed. And so I want to make sure that we continue to think about that and advocate and support each other together. So thank you for your time. I appreciate this. If you have more questions for me or questions that I could help answer from a provider perspective, please put them in. We'll be answering your questions through the Q&A function, also on the on the WOVO app. So on the community boards. So with that said, thank you for everyone that joined. Thank you for your time. And I'm looking forward to seeing together all that we can improve for birth outcomes and optimize the experience of having babies with all women. So thank you.
Hi, everyone. I'm Fletchia for a senior at Tufts University on the conference committee. And I just wanted to take this time to thank you, Dr. Meadows, for your talk on doula's impact in addressing maternal and infant health inequities and just improving overall health outcomes. We'll now transition into any other questions we have for our Q&A session. So please continue to submit any questions you have with the Q&A button, and we'll get to as many as we can in our allotted time. So first up, we have a question from Carmen Simmons. What do you believe the role of family medicine has in maternal and infant mortality?
Yes, I like that question. So I'll go back to saying the slide that discussed, I believe that even in family medicine, we need to educate folks as medical students, as practicing intern resident physicians, as practicing physicians on these data that show the high rates of our human rights crisis, the disparities, and then the relationship to what's happening in society that leads to that. We know that only about 10 or more, oh, hi, Roxanne, only about 10 or more percent, maybe 20 of what we do in the clinical care system in the hospital makes a difference. Around 50% of what we can do in societies make a difference. And people need to understand that. So we as physicians cannot divorce ourselves of the responsibility to understand what those are and or how to connect to those resources. We should be screening for social determinants of health that need to be addressed and referring folks to community resources. And if we can do that, if your practice can set up policies or your institution can set up policies for that, then I think that we could start moving in the right direction.
Thank you. We have another question. If group prenatal care is effective in decreasing PTB, why do you think there's not a more universal or national push for this model?
Catherine, you and I could sit down with coffee for days. I don't know. I keep pushing. And let me tell you, I wouldn't use the word easy, but it was so rewarding to make group prenatal care move forward. It's super important. I keep talking about it. I'll continue to keep using my megaphone to talk about it. I invite everyone else to do the same. It's really important. And I think we should make more of that available and offered for folks. So I'm with you, Catherine.
Quantanese asks, should a pregnancy with multiples automatically be excluded from home birth and birth center options?
I would say that answer depends. So, Quantanese, this is where individualized care matters a lot. And so often the overall answer to that would be, yes, most often multiples will be excluded because there are the monitoring for babies when there are 2, or when you say multiples, 3 or 4, which I used to deliver more triplets and quads in the earlier 2000s. It can get really tricky, and the infant outcomes for the second baby or the second, third, or fourth, whichever baby there are after that, gets to be really dire for them when the monitoring isn't happening the way it needs to. And that can be difficult even on a very high resourced, high volume labor and delivery unit. So I would always recommend multiples be delivered in a setting, because that's what hospitals are for. I don't believe everybody needs to deliver at a hospital. I don't. And as an OBGYN, I will say that on the record. But I do think with multiples, the answer would be yes. I would say though, but I would never say that blanketly and not consider individualized care. And so for each person, I'd want to know who that person is, have them talk to their doctor, review their case and their needs and their care, and then go from there. I'll say that because, as a medical student, I was at a home delivery of a person with multiples because the person had agoraphobia, and the hospital made arrangements to come to this person's house, and we had everything there that we needed to do the delivery. And so I could not say that that person didn't have a home birth, but she had all the resources that she needed. So I would say talk to your physician and I say physician for multiples for sure in that case.
Thank you. Kit asks, how can fathers play a role in reducing inequity? How about in reducing preterm birth?
Oh, fathers. So, there's a lot of people who are trying to do some research. I'm in the middle of our research project. We're looking at fathers. We know that fathers reduce inequities by the social support. And we do know that that marital status also tends to be associated with, for marriage, those who are not single, tends to be associated with better birth outcomes. But the data is not really clear for me, so I can't really say. I know empirically and just by evidence and anecdotally that support throughout the entire pregnancy and at the time of delivery. And boy, I'll tell you, even my husband, like the person that can bring you Gatorade when you're trying to breastfeed, right? Somebody can help you hydrate, so there's milk to come. There's lots of roles that fathers and partners can play, and I think that that's really important. But how that plays out into reducing preterm birth, there's not a lot of data that supports that or explains that.
Amaya asks, are there any movements to include doula care under private insurance? Do you think it would aid in reducing maternal and infant mortality?
I think that the doula evidence is clear thus far that the kinds of supports that people get, especially when women don't have support at all. So when you think of especially the teenage single mom who's having a baby, would having doula care reduce and aid in reducing maternal morbidity, mortality, infant morbidity, meaning preterm birth and mortality? Absolutely. Is there movements for private insurance to cover this? I'm not sure, actually. I do know that there's movements to cover it with Medicaid, but what typically tends to happen in the insurance space is where Medicaid goes, many other private insurers will follow, because Medicaid's had all the demonstration projects to prove the benefit of paying toward that. So I would imagine that they would follow. I don't know of any at the moment, though.
Thank you, Dr. Meadows. Time is up today. We really wish we could get to all the questions, but if you have extra questions, please post them in the community group chats on Cuba as well.
Thank you, Dr. Amuta, for inviting me, and thank you, team, for helping out, and thank you, everyone. I hope you enjoy the rest of the great conference. See you soon.
So Melissa or Kelechi, one of you can stop the recording.